It's a pleasure to present a progressive endothelial cell loss case after phakic lens implantation. The patient was a 40-year-old female after bilateral artisan implantation in 2011 and was referred to us in 2019. Both eyes were affected in high myopia of -11 in her left eye, and postoperatively she was -1 with -1, and therefore underwent the LASIK procedure. In 2013, there was a repositioning of the enclavation in her right eye because of light sensitivity and pain. In 2018, the repositioning of enclavation was conducted in her left eye. Both eyes had an uncorrected distance visual acuity of 0.8. But more important is the endothelial cell count. Preoperatively, it was 2,400 in both eyes preoperatively, but postoperatively, 7 years later, it was 1,200 in her right and 850 in her left eye, and further decreased in January 2019 to 1,000 cells in her right eye and 725 in her left eye. At presentation in Bochum in 2019, 2 months later, the endothelial cell count was 960 in her right and 616 in her left eye. And we asked her to wait and to further measure 5 months later where the endothelial cell counts, and this is a mean of more subsequent measurements at the examination presentation, decreased to 900 in her right and 550 in her left eye, with a best corrected visual acuity of 0.63. Here you see the corneal topography. You can see also a borderline anterior chamber depth, which you wouldn't expect in high myopic eyes, and the decreased endothelial cells. Moreover, you see a slight irregular cornea, and also higher order aberrations with the Wernicke analysis. And here you see the microscopic view of her left eye with the big basal iridectomy and posterior synechiae. And the question, of course, is how would you proceed? Would you do nothing and just wait? Or would you explant the phakic IOL only and ask the patient to wear contact lenses or glasses? Or would you undergo a simultaneous bilentectomy with or without femto, or a sequential bilentectomy with or without femto, or do others? We would and chose a sequential bilentectomy in this case without femto. Here you see the opening of the conjunctiva at 12 o'clock, and then followed by a cauterization of the bleeding episcleral veins. And then it's followed by a broader 5.5 to 6 millimeter inverse scleral incision. And then the paracentesis to the enclavation is conducted, followed by aqueous humor and OVD injection. And then the scleral tunnel is prepared with a diamond blade, and the anterior chamber is opened with the 2.75 millimeter phaco knife, followed by a widening of the incision to create a good inner wound lip with a diamond knife, and the de-enclavation with a blunt enclavation needle, and a special holding forceps that's end grasping. And with this iris manipulator Frankfurt model, the entire lens is then removed smoothly out of the anterior chamber, followed by a suturing of the incision for a tight wound closure. And the next question, of course, is how would you remove the natural lens? Would you use the same incision site with femto? Would you use the same incision site without femto, or use another incision site with femto, or another incision site without femto? And you see already here that we used another incision site without femto. The reason is that our experience is not so good with paraaxial flow if you use the same incision site. And femto, the use of the femtosecond laser is to some extent dangerous in the presence of an anterior chamber lens because the distance to the natural lens is greater, and there is an entrapping of gas bubbles, as well as the rays are distorted. Here you see the temporal approach after the phakic lens has already been removed at 12 o'clock. I'm opening the lens, and you can see there was a slight cataract existent already of, let's say, grade 2. And it's under OVD protection here, and followed then through a clear corneal incision from the temporal side. And the lens removal is using with a phaco tip, but it's more or less without use of the ultrasound after hydrodissection, hydrodelineation. And this is then followed by bimanual irrigation aspiration using this device, where you also can just polish it for polishing. And the next question, of course, what type of IOL would you implant? So you could implant a monofocal IOL, a monofocal toric IOL, or a light adjustable IOL, given the fact that in the left eye there was a keratorefractive procedure, namely a LASIK procedure. And sometimes you even don't know what exactly was conducted, or a light adjustable IOL, or an EDOF IOL or IC8, or a trifocal IOL. So we chose the IC8. The IC8 has an A constant of 120.5, and IOL calculation was based on ray tracing analysis using the Oculix. And the IC8 is a single-piece hydrophobic acrylic IOL with a small mask of 3.23 total diameter and an inner aperture of 1.36. It has a 360-degree square edge design with a 6mm optic and a total diameter of 12.55-degree haptic angulation and an aspheric anterior surface. Here you see the preparation for implantation, and the IC8 is taken out of the container and inserted into the tip. Here you can see the near view of the implant. There is a little opening in the tip to take care of the leading haptic. And here you can see it's holded via a cannula, and then it's inserted. And at that time point, we had to open the incision to 3.5 millimeter because at that point, the new tip design, which also goes through 2.75 millimeter, was not available, which is now standard of care, of course. But at that time point, it was this way. Then the cohesive OVD is removed also behind the lens. And you just suture, without sutures, you can just close the incision. So what was the outcome? That is most important. We implanted a monofocal IOL in her right eye and the IC8, as you have seen, in her left eye. Outcome in terms of refraction was very good, with 0.25 combined with minus 0.25. But more important, the endothelial cell count was in a right eye between 550 to 570 and recovered, interestingly, to 750 to 932 in her left eye 2 months after surgery. We just contacted the referring doctor, and there was no additional endothelial cell loss so far. There was just today, what we asked the referring doctor, uncorrected distance visual acuity was 0.8p in her right eye and 1.0p in her left eye. And interestingly, also the near visual acuity at 40 centimeters was in her right eye 0.32 and 1.0 in her left eye, which is very satisfactory. And the patient also was very satisfied and pleased with her outcome. Thank you for your attention.